أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. Now, today, for the final year students who are preparing the examination and those who are going for the FCPS examination in Pakistan, or those who are preparing for MCPS chest medicine or MCPS family medicine, for them this is the presentation, which is very basic type of knowledge is provided about the clinical application of the pulmonary function tests. I am Professor Syed Ali Haidar, and I am going to share with you this knowledge previously by the clinical application of the pulmonary function tests. So today I want to talk to you something else, and something else is very related to this common thing, and that is the clinical application of the arterial blood gases are concerned. This one, something about the blood gases. This is very fundamental knowledge which I am providing, and I'll try to clear it. Arterial blood gases, ABGs. We know that about it, about the oxygen dissociation curve and how the cell responds with the entry of the oxygen and the carbon dioxide as the end product, and it should go out of the system. So, to maintain the pH of the blood, which is around 7.3 roughly, so this is how the system works. Oxygen coming out of the cell, inside the cell, and the carbon dioxide out of the cell. Oxygen is gained by the lungs, and carbon dioxide is going out of the lungs. In this way, the oxygen and the carbon dioxide, the gas exchange occurs at the pulmonary alveolar septas. The second point is this is to maintain the blood pH. Another important thing is the presence of the bicarbonate ions, which is regulated by the kidneys. The kidney can absorb it, the kidney can excrete it. Again, the hydrogen ions also, kidney can absorb it or excrete it. So there are two organs which are elementary functioning for the maintenance of the pH of the blood. So the internal environment is maintained by the feedback mechanisms. If they are disturbed, then the negative feedback mechanism will work with the help of the two systems, pulmonary system and the renal systems. So you have to maintain the oxygen and the carbon dioxide levels and the bicarbonate levels in the blood. Helping hands, tools, and there are certain substances which are present always in the couples. Like for example, the hydrogen ions and the backup of the trans. In this fashion, the H2CO3 or HCO3, the couples, they are pairs, these type of substances. Is it, for example, the sodium hydrogen diphosphate, dihydrogen phosphate, sodium mono hydrogen phosphate, etc. The phosphate buffer systems. Now these are called buffers because they maintain the pH, they try to maintain the pH to the normal. They help in maintaining the body to normalize the pH. They are called buffers. And the fourth type of the system is the most strongest system, buffer system, is the hemoglobin. You go for the hemoglobin, the oxygenated hemoglobin and oxygenated hemoglobin. A hemoglobin is the most powerful buffer ever described. Remember these buffer systems? Remember these systems, pulmonary function, pulmonary and the renal systems, maintaining the pH to the normal, to normalize around 7.3, 7.25 to 7.3 around. So definition is that you have to calculate the arterial blood gases, arterial, not venous side. So you have to collect the blood from the artery. The most accessible arteries can be carotid artery, it may be superficial temporal artery, it may be femoral artery, it may be any other artery. The easiest accessible artery is the ulnar artery, where we'll take this blood sample. So this is the place where we go for it. Remember that blood should be collected from the arteries, not from the veins. The arterial-based components are the pH. I already said that the measure the hydrogen ion concentration is negative logarithm of the hydrogen ions, which shows blood acidity or alkalinity. With less than 7.25, it is moving towards the acid phase, acidity, and at more than 7.3, it is moving towards the alkaline side. PCO2, partial pressure of carbon dioxide, indirectly measures the carbon dioxide, which is excreted by the lungs now, which is remaining in the partial pressure of the carbon dioxide in the blood now is measured. It is the respiratory parameter. It is the respiratory parameter. Either it is excreted or it is absorbed abnormally. Retention. PO2, partial pressure of oxygen should be the part is the partial pressure of oxygen is PO2, that is dissolved in the blood. It reflects the body's ability to pick up the oxygen from the lungs. SO2 is the saturation of oxygen. There are other components of the oxygen concentration in the blood, you can measure it. SpO2 is measured by the pulse oximeter. It is indirect version. Here you have to go the partial pressure of oxygen from the arterial blood. And there are other components of the oxygen levels you can measure, but it is not important here. In this ABG component is PO2. And the bicarbonate is a metabolic parameter actually, as I already said, is a metabolism, and it reflects the kidney's ability to retain it or to excrete the bicarbonate. In this fashion, the blood pH can be maintained. Normal values pH is 7.35 to 7.45 according to this lab. Around 7.3 is the average one. PCO2, remember, is 30 to 45 millimeter of mercury. Try to remember the normal values. PO2 is usually 80 to 100 millimeter of mercury. PO2, it is not SO2. It is very, very equivalent, but it is not true. You have to go for the PO2. And bicarbonate is, that according to some labs, is 22 to 28, in other labs 18 to 26, 22 to 28 milli equivalent per liter. If you add the electrolytes in it, and the most important electrolytes are the cation potassium. Potassium levels are also very important. If you want to understand the disease process which is going on in the body, which is created abnormality of the pH, alkalosis or acidosis, then potassium levels are important. But it is not actually the component of the ABG. But you should know the potassium levels. I will always stressing my students to go for the potassium levels also. For the collection, these are the things which you have, the syringe and the other things, lidocaine, heparin, 1:1000, etc. It's not important to remember. Patient should be consented and should be explained. Before going, and patient is consented, to perform Allen's test, because you are puncturing the ulnar artery, radial artery or ulnar artery. Radial is palpable, ulnar is not palpable very often, so we will take the radial artery, easy accessible site, because the radial artery and the ulnar artery, they anastomose at the periphery, and the hand blood supply depends upon the dominant supply. So this test should be done. If the dominant supply is only radial, ulnar participation is less, so we will not go for the radial puncture. We will go for the femoral puncture or some other sites to collect the blood. Allen's test should be done. It is usually not practiced clinically, but it should be done. Now, Allen's test is this. First of all, you block the ulnar artery and see compression at the ulnar side and see whether this part of the hand after 1 minute becomes pale, or rather afterwards it become bluish tinge. It means the ulnar is dominant. And then you go for the radial artery, just leave it and go for the compression of the radial artery. If the radial artery is pressed and the hand becomes pale or blue, it means the radial is dominant artery in this patient. So do not go for the radial artery puncture. Leave it. If the ulnar is occluded, nothing happens because it's supplied by this. But if the radial is occluded, the hand becomes pale and cyanos, it means that this is the artery which is the dominant supply of the hand. Allen's test should be done. It is not done usually, but it should be done. So you have to take the blood from this artery, usually. You go directly into this artery, in the radial artery. This is the position, 90 degree perpendicularly. Wash hands, put gloves and sterile. All the things should be practiced. Radial artery 45 degree, 60 degree to brachial and 90 degree to femoral. To cross the radial artery at the 60 degree, usually the people do perpendicularly. Better to go the 45 degree angle. It is standard way to do it. Brachial 60 degree and 90 degree femoral. Now withdraw the needle and apply the digital pressure afterwards. And in the syringe, check bubbles in the syringe. Place the capped syringe in the container of the ice immediately, because the oxygen will be absorbed afterwards. And the levels of the PO2 cannot be checked properly. And other byproducts will be coming into the blood if it is warm. So it should be iced. And the puncture site should be maintained by a firm pressure by 5 minutes so the patient's coagulation abnormalities is disturbing, or he has taken the antiplatelets or anticoagulant, then pressure should be maintained for 10 to 15 minutes at that site. This is the position usually actually should be done like this. Like people are doing exactly 90 degrees. That is wrong. The follow-up phase, label this patient, name, what you want to do, time, etc. Sticker should be placed on that site, and immediately it should be dropped to the laboratory. Immediately. Complications are there: hematoma, hemorrhage, arteriospasm, distal ischemia, infection, numbness. Now this is the aliens test should be done, and then you go for the collection of the sample and you give to the lab, and the lab will report you. The parameters I already told you about it. That is it will give the pH and PO2, PCO2 and bicarbonate levels. On the basis of these four, if potassium is there, it is very fine. It will enhance your interpretation. Now interpretation is pH is 7.30, because normal is already mentioned out, is 7.25, is about 7.28 or 7.25 to this condition 7.3. So the normal pH according to the lab, look the lab what the lab will say is this. In this laboratory, again I will say the lab's normality is important. What we have previously discussed is the ABG components 7.35 to 7.45. If it is less than 7.35, you are moving toward the acid phase. If it's more than 7.45, you will go for the alkaline phase. If it is 7.28 or 7.30, the body is moving to the acid side. If it is more than 7.45, for example 7.48, you are moving this patient to the alkaline side, 7.35 to 7.45. So this was actually 7.35 to 7.45 according to his lab. The average is 7.25 in some labs. You have to see the labs. What they say, the pH is 7.30, 7.35 to 7.45, less than 7.35, it is acidemia. PSO2, CO2 is 55 millimeter. Normally it is around 45 millimeter maximum. It is higher side, the increased respiratory cause. The normal one is about 45, 30 to 45, or 35 to 45. Bicarbonate level in most labs, not all, is 22 to 28. If it is 25, it is normal. PO2 is 80 millimeter of mercury, which is normal is 80 to 100, it is normal. The patient is moving in the acidic phase. He has got acidemia. That is called the respiratory acidosis. Why? Because of the high content of the carbon dioxide. Now carbon dioxide, if you retain in the blood, it will form the bicarbonate first, and it will combine with the hydrogen again to form the carbonic acid. So retention means that the carbonic acid is increased. It means that there will be a respiratory acidosis. If you retain the carbon dioxide into the blood, it will be compensated by this bicarbonate. Another case is the pH is 7.49, because 7.35 to 7.45 is normal to this lab. It is alkalemia. POCO2 is 40 millimeter, which is normal. The bicarbonate is 29, which is less than 22. It is 22 to 28. It is higher, increased. It is metabolic cause. And PO2 is 85, which is normal is 80 to 100. It means it is the metabolic alkalosis. Look this. These are the results which are coming. In acid-base disorders, if the pH is lower down, it means acidosis. Yes, normal is 7.35 to 7.45. PCO2 normal is about 30 to 45. If it is higher, it means retention. Now this is a retention because of the carbonic acid is formed. Bicarbonate is the normal. It means that the pH is lower down, it is respiratory acidosis. Bicarbonate is normal, only the retention of carbon dioxide causing the respiratory acidosis. Another condition, pH is higher, PaCO2 is lower down, less than which is given in the lab is 30 millimeter. Then it is the carbon dioxide which is you have expired in more expiration, tachypnea, more oxygen is going out. So carbonic acid is not formed into the blood normally. It's lower down. And because of this, the pH is higher. Carbonic acid is lower down. PCO2 means carbonic acid. Indirectly, I said carbonic acid, serum carbonic acid levels are down. It is acid which is down, the pH should be definitely around it. This is the alkalosis. PCO2 is retention, and it is exhaling, you are exhaling it. So carbon dioxide is not there because level is down, pH is up. That is why alkalinity occurs and it is called respiratory alkalosis. On the other hand, the pH is down, the PCO2 levels are normal, that is about 45, 35, 32 to 35, 45, and bicarbonate level normal was 22 to 28 milliequivalent, it is down. It means that it is in the acidic phase, pH is down, and causes this, not this. It is called metabolic acidosis. On the other hand, the pH is up, the PCO2 is normal, the bicarbonate levels are higher, more than 28. 22 to 28 is normal, 28. The cause of the higher pH means alkalosis, and the higher bicarbonate levels causing the metabolic alkalosis is on the higher side. The compensation occurs, I already said, if the respiratory is the cause, then kidney will function. If the kidney is the cause, or some other than that is the cause, the respiratory system will negatively feedback activate it and try to compensate it, the pH to the normal values, 7.35 to 7.45. Now, when the respiratory acidosis is the concern, look, the compensation occurs or not. Phase is uncompensated, pH is lower down, acidosis is there because the tension of the partial pressure of carbon dioxide is higher, but bicarbonate is not acted yet. The second part is this, partially compensated, means pH is, this is the main thing, stressing the pH is lower down. The partial pressure of carbon dioxide is higher as previously, but bicarbonate now, because it is the acidosis, carbonic acid is more formed, the bicarbonates are increased in the blood. The kidneys will not excrete the bicarbonate, and it will be retention of the bicarbonate in the kidneys for the compensation. It is not completed yet because the pH is lower down. It is partially compensated. They are although the kidney responding, but it will take time. After some time, full compensated, now pH is normal, partial pressure of the carbon dioxide still is higher, although it will take time to become normal, and this is the target actually. Bicarbonates are increased in this case, and this is full compensated. Now the patient is out of danger. pH returned to the normal, pH2 levels are still high to correct acidosis. Another condition is alkalosis. Respiratory alkalosis, uncompensated, pH is higher, more than 7.45. It means bicarbonates are not touched here, PaCO2 is reduced, so carbonic acid is not forming in the blood to the normal levels. In this fashion, the pH is increased because of the low level of the carbonic acid in the blood. It is uncompensated. Partially compensated, pH is still higher. Although the bicarbonates, they are reducing now. Kidneys are excreting. They are now on the edge of the skin excretion, and PaCO2 level is still there lower down. It is partially compensated. It will take time. The system will take time. And fully compensated, what is thing is the pH. It is normal now. Although PaCO2 is lowered, still it will take time to become normal. The cause should be removed, which causes the lowering of the PaCO2. It will take time. Our body responded by excreting the more bicarbonate from the kidneys, so which is fully compensated. Everything is fine. And this is the target which is achieved. It is fully compensated. On the other hand, the uncompensated metabolic acidosis means that pH is down. Okay, it means that it is less than 7.35. PaCO2 is normal, but bicarbonate levels are down. It means that the pH is less than 7.35, and the cause is here. Low bicarbonate levels. Many conditions can cause it. Partially compensated, the pH is still down, and this will activate the respiratory system. The respiration to becomes overactive. It is now in action. More carbon dioxide is excreted out, so the carbonic acid levels are down in the blood. But still the pH is not normal, because it will take time. After some time, what happens that the pH becomes now normal, bicarbonate levels are still they are reduced, so it will take time. What is the cause of the bicarbonate levels? For the reduction, it should be managed, and PaCO2 will respond afterwards, and it will become normal in the next phase. The patient is in the normal pH, normal. You have achieved your goal by the negative feedback mechanisms. No pharmacological agents are needed here. But the metabolic alkalosis is considered uncompensated. If it is uncompensated, means that the respiratory parameter is normal. The metabolic parameter is high. Bicarbonate level is more than 28. pH is high, uncompensated. If it partially compensated, means that pH is higher. It is more than 7.45. The metabolic parameter is higher still because of some cause which is there. The kidneys are responding in the negative feedback mechanisms, and it will become increased. Retention of the carbon dioxide is now mounting. Carbonic acid is now forming, but pH is still on the metabolic side, alkalosis side. The next phase occurs where the action of the or retention of the carbon dioxide in the blood will cause the pH to become normal, although still the PaCO2 is on the higher side and bicarbonate. You have to, the body will take time, or the cause should be detected for this bicarbonate levels, higher bicarbonate levels. If you detect it and manage it, the PaCO2 becomes automatically become normal. Normally it is about 30 to 45 millimeter of mercury in most of the cases. Now this is how the body is responding for the change in the partial pressure of the carbon dioxide, means carbon dioxide retention or its excretion, and bicarbonate retention or its excretion. So it is the play which is going on in the body. The tutorial, it is a tutorial means that some few examples are given. All should not be addressed. It is not possible. For example, Mrs. DS is a 45-year-old female admitted into the nursing unit with a severe asthmatic attack. She has been experiencing shortness of the breath since admission 3 hours ago. Her arterial blood gases result is as follows. pH for 7.22, normally 7.35 to 7.45. It means that it is acidemia. PaCO2 is 55. 45 is the limit of the PaCO2. It is now more partial pressure of carbon dioxide, more carbon dioxide is retained in the blood. This is the cause probably. Because actually on the clinical ground, the patient's lungs are compromising actually. Bicarbonate level 25 is still normal. It is not touched. So it is the what is called partially. Here we say that the patient is suffering from the respiratory acidosis. The first step is to assess the pH, it is low, therefore we have acidosis. Assess the PaCO2, it is high in the opposite direction of the pH. Assess the bicarbonate, it remain normal range. It is compensated by the bicarbonate levels. It should be activated, the kidney should be activated to excrete it. It is uncompensated respiratory acidosis. The another example is Mr. WR is a 45-year-old male admitted with a recurring bowel obstruction. So intestinal problem is there. He's been experiencing intractable vomiting. Vomiting means you have to vomit hydrochloric acid, hydrogen is going out of the blood. For several hours, here is the arterial get result. Because hydrogen is going out, chances of alkalosis are more. The clinical laboratory, pH is 7.5. Yes, there is 7.35 to 7.45 is normal. So it is alkalemia, alkalosis. PaCO2 levels is not touched, is normal, 35 to 45, normal. And bicarbonate levels is 33. And this is very, very high. Normally 22 to 28. So metabolic parameter is disturbed with the clinical scenario. This is uncompensated type of metabolic alkalosis. The same thing, the negative feedback mechanism will be activated next. That is the PaCO2 levels which are normal. Now you have to increase the acid levels in the blood by retention of the carbon dioxide. Now you are asked to see a 63-year-old female who was admitted with a shortness of the breath. On arrival, the patient's drowsy and 4 liter oxygen via nasal cannula was going on. You perform ABG, the PA2. Here is 20 partial pressure of oxygen. 20 here means, in this case, it is about 90%. pH is 7.29. It is alkalosis because normal is there. PaCO2 is 9.1, is KPA 4.7 to 6. It means it is the PaCO2 is about 55 to between 55 millimeter. Normal is 45. It is more than that. The patient is in the respiratory type of alkalosis. Bicarbonate is not touched, is normal. This is the case of the uncompensated type of the respiratory alkalosis. Another example, a 17-year-old patient present to the A&D complaining of the tight feeling in the chest, shortness of the breath, some tingling in their fingers, around their mouth. They have no significant past medical history and not on any regular medication. ABG performed while they are breathing at the room air, and the result as shown. PA2 is 14. Still it is very good. It is about 85%. pH is 7.49. It is more than 4.5, 7.45. It means that it is alkalosis. The parameter, look the parameters here. The system is in the chest, shortness of the breath. Levels of the PaCO2, because of the depression of the respiratory system, it is 3.2, means that it is less than 20 or 22 millimeter. Normally it is about 30 to 45 around. So it means the retention occur is the partial pressure of carbon dioxide. It is alkalosis. It is compensated by this. The respiratory system is, because the system is actually the carbon dioxide, you remove the carbon dioxide is out. The respiratory system is affected, basically. Respiratory parameter is disturbed. This alkalosis is respiratory alkalosis. It is not yet compensated, uncompensated type of the respiratory acidosis. Another case is PA2. I'm not reading this scenario because of lack of time. It is 12.7. It is around 92%. pH is 7.50. It is more than 0.45. It is alkalemia. PA2 is 5.5. 5.5 means it is normal range between 35 to 45 or 32 to 45. Bicarbonate level, it is 29, is higher. It is the metabolic part which is disturbed. So it is the metabolic type of the alkalosis. It should be compensated by the carbon dioxide. Carbon dioxide will be, retention should be occurred, so the carbonic acid is formed. Another scenario is that PO2 is 9.1 in this patient. 9.1 means that it is about lower down to 55% to 60% oxygen. Hypoxemia. pH is 7.30. It is acidemia. PaCO2 is 8.4. It is 60 millimeter PaCO2. It is normally about 45. The system is actually here, which is probably in problem. It should be compensated by what? If it is the respiratory system. You have to go for the bicarbonate levels. And bicarbonate levels should be, because it is the acidosis, it is responded 29, higher side. But pH is still 7.30, it is partially compensated. It is partially compensated type of the respiratory acidosis. Partially compensated, not fully compensated. Another case, PO2 is 12.4, means that is about 90%. Okay, fine. pH is 7.29, is higher. It means acid alkalemia is there. PaCO2 levels are 5.5, that's normal. The metabolic parameter is 15 less. It is the case of the metabolic alkalosis. It should be compensated by the PaCO2 if it is active. So we need more carbonic acid now, more than 6. More than 6 means that it should be 45 millimeter, 60 millimeter compensation. It is uncompensated type of the metabolic acidosis. PO2 is 13, pH is 7.3, 13 is normal, pH is 7.3, is lower down, acidemia, PCO2 is 4.1, means that it is less than 35 or 30, is lower down. Lower down means that it is out, you have exhaled much carbon dioxide. And the bicarbonate level is 13. 13 means that it is lower down. If it is lower down, PA2, first of all, look this. If it is lower down means that the blood has exhaled carbon dioxide and the carbon levels are decreased. The pH should be on the alkaline side, not on the acidic side. But look this, it is 13. If it is 13 means that it is the level which is reduced, it is on the acidic side. And this side is important. It is the metabolic actually acidosis which are now under compensation by the respiratory system. It is the partially compensated type of the metabolic acidosis. Last example I will give, because you can pick lot of, in your book and in Google you go for it. PO2 is 7.9, hypoxemia is there about 60% oxygen, pH is 7.31, it is lower down, mean acidemia. There are two parameters left. Whether the cause is this or this. Now PaCO2 level 7.1 is higher. Means that it's higher means that it is the retention of the carbon dioxide in the blood. It is the blood, more carbon dioxide is found, pH should be lower down. It is respiratory acidosis. It should be compensated by this bicarbonate, which is not either is normal, it is uncompensated, not partially, sorry, it is uncompensated type of the respiratory acidosis. If pH becomes normal in any case of this case, although these levels are variable, that it is fully compensated. Partially compensated means that one is activated, either this is activated carbon dioxide levels in the blood or the bicarbonate levels. They are under action. First of you detect it is acidemia or alkalemia, partial pressure oxygen normal or not. Go for the PCO2 levels, go for the bicarbonate levels, and see what is the basic cause and what is the compensatory under compensation. Now in this fashion you are going to a lot of cases. I can speak hours on it. But the basic information has been provided to you. I think you have understood how to interpret the arterial blood gases. People ask me that you have got very, very prolonged lectures have been given by you. Time you have taken much. Now this is the time I have to take time to clarify myself. I hope that you have understood it, and inshallah ta'ala, if you will repeat this tutorial, inshallah you will be benefited. 2 or 3 times you will repeat, try to evaluate case from the Google. Okay? See you next time. On the next, I will go for the specific diseases of the lungs. Allah Hafiz, wa ma alayna illa al-balagh.